Good afternoon, everyone. It is officially afternoon. So I have the great pleasure of introducing Dr. Hansen. Very excited that you're here with us. And I promised you, Dr. Hansen, that I would be very fast in reading your bio, but this is very important that everyone knows about your work. So here goes. Dr. Hansen earned an MD and PhD in cultural anthropology as part of Yale University's NIH-funded medical scientist training program. She is professor and chair of research theme in translational social science and health equity at UCLA's David Geffen School of Medicine. During graduate school, she completed field work in Havana, in Cuba, on Cuban AIDS policy, and in Puerto Rico on faith healing and evangelical Christian addiction ministries, founded and run by self-identified ex-addicts. Her work has been published in both clinical and social science journals, ranging from the Journal of the American Medical Association and New England Journal of Medicine to Social Science and Medicine and Medical Anthropology. After graduate school, she completed a clinical residency in psychiatry at NYU Medical Center Bellevue Hospital, during which she also undertook an ethnographic study of the introduction of new addiction pharmaceuticals. She examined the social and political implications of clinician efforts to establish addiction as a biomedical rather than moral or social condition, as well as the ways that neurochemical treatments may be reinscribing hierarchies of ethnicity and race, which informed her current book project, White Opioids, with policy analyst Jules Netherland and historian David Herg. She just completed a feature-length visual documentary based on this work, Managing the Fix, which debuted at the annual meeting of the American Psychiatric Association. Her book, Addicted to Christ, Remaking Men in Puerto Rican Pentecostal Drug Ministries, was published by the US Press in 2018. She is also leading a national movement for training of clinical practitioners to address social determinants of health, which she and Jonathan Metzl call structural competency. Thank you for that work, Dr. Hansen, and which is the subject of her second book, Structural Competency in Medicine and Mental Health, a case-based approach to treating the social determinants of health, with co-editor Jonathan Metzl, published by Springer in 2019. Her third book, Whiteout, How Racial Capital Changed the Color of Heroin in America, is forthcoming from the UC Press. She is the recipient of the Robert Wood Johnson Health Policy Investigator Award, Kaiser Permanente Bursch Minority Leadership Award, an NIH Award, a Mellon Sawyer Seminar Grant, the NYU Golden Dozen Teaching Award, and the American Association of Directors of Psychiatry Residency Training Model Curriculum Award. Please join me in giving a warm welcome to Dr. Hansen.
Thank you so much. I want to thank you, Barbara Krishnan, and the UCSF Fellowship Program in Child and Adolescent Psychiatry for this great opportunity to be in conversation with you about an evolving problem. And I want to let you know that I'm going to examine race and health from an angle that's still pretty unusual in medicine, and and in psychiatry. That's by examining the mechanisms of whiteness. So I'm going to share a case study of the hidden but active maintenance of white exclusivity in medicine as the cause of what we often talk about as quote unquote health disparities among the quote unquote underserved minorities, groups typically described in a passive manner as quote unquote lacking access to care. So I'm going to paint a picture of a process that's more active and deliberate than that. So whiteness is central to our environment of profit motives, commodification, and the use of racial hierarchies to segment and open markets. It involves the mutual racialization of drugs and people. Drugs can be white, as in targeted to white people. And they can also pharmaceutically enhance the whiteness of people whose privilege is in question because of stigmatizing diagnoses like addiction. So I'm going to attempt to share my screen. I have a few things to show you today. Okay. Does that look good? All right, great. All right. So I first encountered office-based medication for opioid dependence in the late 1990s as a medical student working on the early clinical trials of buprenorphine, which would later be manufactured with naloxone under the commercial name Suboxone. My attendings at the time were excited about buprenorphine, which they said was about to quote unquote change the culture of medicine. And that was by defining addiction as a chronic disease, treatable alongside diabetes, hypertension, and asthma in the same clinics, primary care clinics, and in the same way with pharmaceutical maintenance. So this caught my ear as an MD PhD student, cross-training in cultural anthropology. And I asked myself, what could it mean to change the culture of medicine? What would drive this change? And as it turns out, my attendings were right. In the course of my career, I've witnessed a profound change in the way that clinicians frame addiction. My field of addiction treatment swang from a drug-free philosophy in the 1990s to opioid maintenance as first line of treatment by the 2000s. And as I completed an addiction fellowship and took a faculty position in psychiatry and anthropology, I also documented stark differences between buprenorphine patients and methadone patients by race and class. So what began as a study of culture of medicine became a study of how the opioid crisis came to be seen as white. With white, ironically at the same time, so this is ironically at the same time that racially targeted drug war policies led to mass incarceration of Black and Latinx Americans and gave the US the highest incarceration rate in the world. So tonight, I'm going to give you an analysis from my forthcoming book on opioids and race based on research supported by NIDA, the Robert Wood Johnson Foundation, and the American Psychiatric Association, as well as the New York State Office of Mental Health. While narcotics have long been criminalized through association with marginalized racial groups, such as turn-of-the-century images of Chinese opium dens, Negro cocaine fiends in the South, as well as Mexican marijuana madness, we don't often look at how symbolic association with white middle-class markets has legitimated the widespread prescription of narcotics, including post-World War II epidemic overdose from barbiturates and benzodiazepines that haunted white middle-class America. We rarely ask how a drug can assume whiteness within a pharmaceutical logic based on race. And yet this process of pharmaceutical whiteness is at the core of the widely asked question, why is the life expectancy of white people suddenly falling while the life expectancy of almost every other racial ethnic group is rising? And how did overdose become their primary immediate cause of excess death? So I want to go beyond the received wisdom that unemployed white people in the post-industrial Rust Belt turned to opioids for solace. That might be true, but it begs the question, why opioids, why white people, and why now? So I'm going to argue that the current generation of opioids were designed to have white racial identities, and that in our stratified healthcare and justice systems, the social technologies shaping opioid consumption reinforce racial inequalities while at the same time harming white people. So key to this story is an unrecognized form of ethnic marketing that, because it targets white people, works by not marking itself as racial. The story is invisible by design. It was only through years of observation and interviews with key actors that I've been able to unravel its threads. I've observed drug policy and addiction science meetings, clinical interventions over 6 years, and interviewed almost 200 addiction scientists, treatment advocates, pharma executives, policymakers, administrators, prescribers, and patients. So let's start with where I started this study, which is Suboxone. It's easiest to see its racial identity by comparing it to its predecessor, methadone. Here's a bar graph from the first and last, no, it's actually the first, not the last, nationally representative study to compare buprenorphine patients to methadone patients by race and class. And this was some geographic mapping of buprenorphine versus methadone that I did in the 5 boroughs of New York City that confirmed the patterns. But even more recent studies have confirmed that buprenorphine is more often prescribed in private markets in white middle class areas. So white patients with opioid use disorder are 3 to 4 times as likely as Black patients with opioid use disorder to be prescribed buprenorphine. So what we don't know from graphs like this is by what process did buprenorphine and methadone gain their racial identities? So for that, we have to go back in time. Let's go back to 1965. Race riots have burned through Harlem. Philadelphia, and Watts, Los Angeles. The unemployment rate for Black people is twice that of white people. Organized crime gains control of Asian heroin imports and recruits a sales force from Black and Latinx inner cities. Meanwhile, Rockefeller University metabolic researcher Vincent Dole, who thinks of heroin addiction as opiate receptor deficiency analogous to insulin deficiency in diabetes, publishes his findings from the first clinical trial of methadone maintenance. So this was 1965, Annals of Internal Medicine. The study's subjects are African-American heroin injecting men from Harlem, and its outcomes of decreased criminal activity and increased employment at 6 months brings it national attention. By 1970, news of methadone as a pharmacological answer to urban heroin reaches President Nixon, who appoints pioneering methadone psychiatrist Jerome Jaffe as the nation's first drug czar. Nixon targets inner city Blacks and Latinx people, as well as returning Vietnam veterans, with methadone, his major weapon in the war on drugs. So to prevent diversion and street sale of methadone, the DEA regulates methadone clinics and requires daily observed dosing and regular urine testing. Due to community resistance, NIMBY syndrome, the clinics are located in marginalized neighborhoods in the city, remote from other medical services. So from the beginning, methadone has had only a quasi-medical status. Let's fast forward to October 8th, 2002. A new kind of opioid problem has developed following Purdue Pharmaceutical's aggressive marketing of OxyContin as a quote unquote minimally addictive pain reliever. Most of these newly dependent people are white, and many of them are affluent to middle income. The FDA has just approved the synthetic opiate buprenorphine, commercially packaged with naloxone as Suboxone, for maintenance treatment of opiate dependence in buprenorphine certified doctors' offices. Pharmacologically similar to methadone in that it blocks opiate receptors in the brains of addicted patients, buprenorphine can be prescribed monthly for use at home, while methadone is still restricted to DEA-regulated clinics with directly observed dosing requirements. So office-based buprenorphine represents a reversal of national policy. It's the first time since the 1914 Harrison Act that private doctors have been permitted to use opioids to treat opiate dependence. So to accomplish this, the manufacturers of buprenorphine and the architects of buprenorphine policy had to distinguish buprenorphine symbolically and spatially from methadone. Buprenorphine, in a nutshell, pharmacologically in the same drug class as methadone, had to be whitened. So this is Mike, and I'm actually going to attempt to show you the video that goes along with this imagery of buprenorphine advertising. So let's see how this works. I should have, okay, let's see if Mike's story is up here. Here we go.
My name is Mike. Played football in high school, sang in the church choir, and classic American upbringing. I used to look at people who used and abused drugs as people who were making a choice. They chose to do that. How could it happen to me? In 1999, we were remodeling our restaurant, and somehow I hurt myself. Our family doctor was on painkillers. Took it as directed. By the time 2004 came, my life was just completely a mess. My body could see 70, 80, 100 without thinking about it. I felt guilt, I felt shame, I felt dirty. This disease devours your total being. I had to get better. Not just did I find a tool that would work for me, but I found one that would let me continue my life. Being able to visit a doctor like an ordinary patient has made all the difference in the world in my recovery.
Okay. So I'd like you to play anthropologist for a moment and just consider the racial and class coding in this ad with regard to who is buprenorphine intended for. And also consider what a huge shift from the image of who is an addict or who is addicted this represents from prior media representations of heroin and opioid addiction. So here we have Mike. He's seated in his Ohio diner, flanked by American flags, talking of returning to coaching his son's baseball team and singing in his church choir. after buprenorphine rescued him from a prescription opioid habit following a back injury. So Mike, in essence, is redefining being in buprenorphine treatment as an American apple pie thing to do. But I want to argue that the ad was just the tip of the iceberg, that the whiteness of buprenorphine was actively achieved by specific social technologies. So I'm going to give you an example of, or an analysis of the contemporary white opioid crisis in terms of what I call technologies of whiteness. So that is neuroscientific metaphors, policy and industry strategies that maintain racial boundaries around biomedical uses of opioids. And this scheme is informed by whiteness studies, which is an offshoot of critical race theory. And it proposes that, number one, whiteness is a category of exclusion and therefore requires cultural and political maintenance of its boundaries, meaning who counts as white and who doesn't. Second, white race is unmarked in US society. It's the assumed norm. Up until the 2016 presidential election, it was rarely explicitly named either in public policies or in the media, meaning that if race is named in media reports, still to this day, you'll notice that on the whole, if the race of a person is named in a media report, it tends to be someone who's not white. A white person is just assumed to be human. That usually, unless the story is about whiteness in particular, an American is assumed to be white. So race is not mentioned, the person is white. This also relates to the colorblind ideology that Michelle Alexander, author of The New Jim Crow on Mass Incarceration, produces inequality by eliminating racial references from racially targeted drug policies and practice. So some of you who've read the book, you know that she highlights, for example, the 1986 Anti-Drug Abuse Act instituted under President Reagan, which mandated 1/100th the weight of crack cocaine as opposed to powder cocaine would trigger minimum sentencing, despite the two, crack and powder cocaine, being pharmacologically similar. And race was never mentioned in that legislation, even though it was clear that it was racially targeted based on the media imagery and policy debates around who was crack addicted as opposed to addicted to powder cocaine. So third, whiteness is defined by its other. White on one hand, and black or non-white on the other hand are interdependent. Punitive American drug policy has long had a mutually defining twin of legal narcotics for white people who've had access to personal doctors, starting with morphine and over-the-counter heroin for middle-class Victorian housewives, and then moving to post-World War II barbiturates, stimulant diet pills, and Valium, otherwise known as suburban mother's little helper, and now back to prescription opioid pain relievers. And then lastly, white privilege has its costs. Not only do white consumers pay inflated prices for patented prescription opioids, but they also pay with their lives in the form of overdose by lethal substances to which they have quote unquote privileged access. So the four technologies of whiteness that I'll be discussing include first addiction neuroscience, new biotechnologies, regulation, and then marketing. And I'll start with the least visible technology of race making, which is brain science. Let's place buprenorphine development on the backdrop of President Bush I's decade of the brain. So this was an era in which NIDA, National Institute on Drug Abuse, was directed to look for neuromolecular bases for addiction in anticipation of breakthroughs from the Human Genome Project. In the process, NIDA renamed addiction a quote unquote chronic relapsing brain disease. And this was supported by leading NIDA researchers who co-authored this widely cited article in Journal of American Medical Association in the year 2000, the end of the decade of the brain. In it, they argued that narcotics dependence was comparable to diabetes, asthma, and hypertension in terms of heritability, treatment adherence, and relapse rates. And as such, it should be treated as a chronic medical disease. The scientists involved in this movement had a social justice intent. They wanted to destigmatize addiction by demonstrating it's a legitimate biological condition and not a problem of morality or choice. What they didn't anticipate was that scientific universalism, because it implied a standard white male subject, would help open white markets to new opioids, and that the unequal ways that biotechnologies are disseminated would enhance the social stratification of addiction. So for instance, brain images like this one, by taking out the subject and his or her trappings of gender, race, and class out of the picture. And by taking the offending organ, that is the brain, out of the body altogether, the image symbolically conveys this unmarked universality of addiction physiology. Neuroscientists further reduced causation to molecular action at neuroreceptors, the ultimate disembodiment of addiction. So the apparent universality of this molecular model implied an assumed white norm. It took a problem long associated with Black and brown crime and gave it new implicit associations with white people. In the process, however, it excluded social conditions. The scientists involved wanted to counteract a drug war mentality by erasing the social context of drug use. Yet they paradoxically set the stage for renewed racial stratification of opioids. Okay, the next technology of whiteness is new biotechnologies. So the neuroscientists that I described just now unwittingly aided corporate strategists that capitalized on this erasure of the social. Building on the neuroscientists' ideology of technological solutions to addiction, in 1996, Purdue Pharma got FDA approval for OxyContin as a quote unquote minimally addictive pain reliever suitable for chronic management of moderate pain. And this was based on its patented sustained release capsule technology, which in theory lowered the reward for users by preventing an initial rush, preventing a big release of oxycodone inside the capsule. The manufacturer influenced the National Joint Commission on Hospital Accreditation to call for pain to be aggressively monitored and treated as the fifth vital sign, along with, for example, heart rate, respiratory rate, temperature. And drug reps advised, just as an additional safeguard though, drug reps advised new opioid prescribers to direct OxyContin to quote unquote trustworthy patients. So in a national clinical workforce that's long been shown to suspect non-white patients of drug abuse, this implied white patients. This was coded language for white patients. Of course, what the model of addiction proof biotechnology left out was the social inventiveness of drug use. So OxyContin users interested in a rush, a big release of oxycodone, quickly learned to crush and snort or inject the contents of these capsules. After steep increases in opioid misuse and overdose, public pressure mounted for intervention. And as of August 2010, just as the original formulation on OxyContin ran out, Purdue Pharmaceuticals introduced its tamper-resistant time-release formulation, which embedded oxycodone into polymers that convert tablets into gummies should users attempt to crush and dissolve them. So impossible to inject. By keeping prices high and representing OxyContin as technologically sealed off from misuse, the manufacturer strove to keep OxyContin symbolically a step ahead of urban non-white street markets. Another biotechnology developed specifically in response to the white suburban and rural prescription opioid epidemic is buprenorphine itself. Combined with opioid antagonist naloxone and branded Suboxone, Reckitt Benckiser Pharma promoted this combination as a smart drug. Although buprenorphine is an abusable opioid, the naloxone with which it's manufactured causes withdrawal symptoms if injected, but not if dissolved under the tongue as prescribed, since naloxone can't be absorbed sublingually. Buprenorphine also poses a lower risk of overdose death than other opioids. So in the 1990s, NIDA subsidized Suboxone's manufacturer with $23 million to test it for use in addiction and sharply distinguished it from methadone, lobbying Congress and the DEA to lower the abuse potential rating of Suboxone from Narcotics Schedule 2, which is where OxyContin and methadone fall, to Schedule 3, along with codeine cough syrup. And this is what made it possible to prescribe Suboxone in private doctors' offices. The manufacturer also lobbied Congress to get Suboxone included under an orphan drug designation to promote, which was originally designed to promote pharmaceutical development for unprofitable diseases in low-income countries, such as malaria drugs. Suboxone's designation as an orphan drug got it a patent extension through 2009 on a drug initially developed in the 1960s. In a race and class stratified healthcare system such as the US, where access to general doctors is often limited to those who can pay, patented expensive technologies for private office delivery in themselves encode white race and middle class. Okay, and then the third technology of whiteness, which is regulation. Although by 2004, prescription opioids overtook heroin as the primary opiate of abuse in the US, the arrest rate for their illegal possession was only 1/4 that of possession of heroin, and arrests for illegal sale of prescription drugs was less than 1/5 that of arrest for selling heroin. Not coincidentally, the non-medical use of pain relievers was twice as high among white people as Black people at the time, while rates of heroin use among Black, Latinx, and white people were almost identical. Since suburban and rural white opioid users were not politically popular targets for drug law enforcement, the DEA and other regulators focused surveillance and enforcement on prescription opioid prescribers and pharmacists instead. And one sign of this has been the spread of prescription drug monitoring programs, which I'm sure you've all encountered in California, enacted in 49 states, half of which mandate prescriber participation with threats of loss of license and prosecution. So returning to buprenorphine, otherwise known as Suboxone, the Drug Addiction Treatment Act, DATA, was passed by Congress in 2000 and enabled any certified physician to prescribe Suboxone in the privacy of their own offices. In congressional debates leading to the passage of DATA 2000, there's a clear emphasis on a quote unquote new kind of drug user, one that's young, suburban, and quote unquote not hardcore, that is implicitly white. Recorded testimony from federal officials stressed that buprenorphine was uniquely appropriate for a new kind of opioid user as opposed to methadone, quote, which tends to concentrate in urban areas and is a poor fit for the suburban spread of narcotic addiction, end of quote. Then Health and Human Services Director Donna Shalala was but one of many officials who noted that buprenorphine as an alternative to methadone would serve, quote, a new kind of addict, end of quote, including citizens who would not normally be associated with the term addiction, end of quote. So with this racially coded language in which suburban and new kind of addict referred to middle-class white people, DATA 2000 passed Congress and reversed 80 years of federal prohibition of private physician opioid maintenance for opioid dependence. DATA 2000 kept the restrictive methadone system intact and did nothing to alter the drug laws that mandated inner city heroin users to prison, but it did create a new treatment track for those who had the resources to take advantage of it. So to give additional assurance to the DEA that buprenorphine would not spill over into illicit markets, buprenorphine's manufacturer, along with the Federal Substance Abuse and Mental Health Services Administration, SAMHSA, developed an 8-hour certification course, which I believe many of you on this call may have taken. It was required for doctors to prescribe buprenorphine, and it was the first and only, that made it the first and only prescription drug in the US to come with such an additional training requirement. Public sector doctors tell me that the certification requirement is a major barrier to making buprenorphine available to low-income people because public clinics do not provide time or incentives to pursue certification, while prescribers in the private sector can charge fees in the New York City area anyway, of up to $1,000 for an initial half-an-hour induction visit for buprenorphine. So the shortage of public sector prescribers, along with the cost of buprenorphine, have long kept buprenorphine in the private sector. And then the last technology of whiteness, which is media and marketing, or ethnic marketing. OxyContin's legendary commercial success hinged on its designation as a minimally addictive opioid analgesic. When OxyContin was under review at the FDA, Purdue estimated the addictive potential of OxyContin to be less than 1% based on testing among terminally ill cancer patients for a 3-month period. In 1996, the FDA accepted this claim, enabling Purdue to open an opioid market that had previously been restricted to those with severe acute pain, like post-surgical or cancer pain. So, prior to OxyContin, opioid pain relievers really were for specialists to prescribe. But with the advent of the approval of OxyContin for moderate pain, a much larger markets of patients with moderate chronic pain like lower back pain opened up. And patients that were seeing primary care general doctors rather than specialists. Purdue hired almost 700 drug representatives and canvassed a call list of 100,000 physicians in the first few years, targeting general doctors in white suburban and rural areas that served patients that the public and the DEA did not think of as at high risk for addiction and drug trade. Purdue's strategy was successful. It led to a tenfold increase in prescription opioids nationally, with disproportionate uptake of OxyContin by prescribers in white suburban and rural areas of states like Maine, Ohio, Kentucky, and West Virginia. In a newspaper content analysis that I completed, I found that in contrast to articles about the criminality of Black and Latinx drug users, suburbanites addicted to OxyContin were portrayed sympathetically in the media as victims of overprescription or as people struggling with real or existential pain. Ironically, Purdue's technological response to the first wave of white prescription opioid overdose deaths, that is, their tamper-resistant formulations of oxycodone, combined with the new prescription drug monitoring programs that I mentioned, led many of these opioid users to look for heroin when pills became hard to get. And one consequence of this was a whitening of the media coverage of heroin users who'd long been portrayed as Black or brown. So this is a school teacher in suburban New York. And this is a college athlete in Arizona. And these are just two of myriad images that came out around the new face of heroin around 2013. The targeted intervention for these new heroin users, buprenorphine, otherwise known as Suboxone, was marketed to middle-class insured patients over the internet. And you saw an ad in Mike's story, one of these ads. So Mike's story is you can see it actually. Oh no, maybe you can't see Mike on this image, but Mike's story is embedded into this website, which is sponsored by the manufacturer of Suboxone, Reckitt Benckiser Pharma. And just, I invite you to look at the race and class coding on this website of who buprenorphine is intended for. So this same website features a link to a Suboxone prescriber locator service created by the Federal Substance Abuse and Mental Health Services Administration. So if you look in the lower left-hand corner, you see a tab, patients find a buprenorphine physician. If you click get started under that, then you will get a chance to enter your zip code into a browser, and you'll get a printout of buprenorphine certified prescribers in your area, the majority of which will be in private practice. So these strategies created an exclusive yet lucrative segment of the market for Suboxone, making it a blockbuster drug at over $1.5 billion in sales in the US per year by 2012, second only to OxyContin in that year, which reported $3 billion of sales in 2012. So this racial segmentation of drug markets into licit and illicit, white and Black, clinical and recreational, creates a moving target of time-bound patents on new technologies targeting the white middle class. And this is an old cycle, started by Bayer Pharmaceutical's own heroin, marketed as a non-addictive treatment for morphine addiction among middle-class Victorian housewives in 1898, and as an added household use, a highly effective cough syrup for children. So these were the initial uses of heroin. What can we learn from this as clinicians, researchers, and policymakers? So I want to argue first that magic bullets are a myth. As the failed promises of OxyContin's sustained release capsule and of the inability of unilateral buprenorphine promotion to stem overdoses has shown, biotechnology alone cannot stop the harms of narcotics without systemic and social intervention. And to underscore this point, I'm going to turn to an international comparison often used by American advocates of buprenorphine expansion, and that's France. So in France, where buprenorphine was adopted for general physician treatment of opiate dependence in 1995, it was billed not as a stigma-reducing agent for a middle-class market, but as a public health intervention to stem overdose and HIV among low-income, largely immigrant heroin injectors. Buprenorphine was widely adopted among primary care doctors in poor communities in France, which, by the way, is a country with universal healthcare. So I just want to underscore universal healthcare. Contrast this. Oh, so, and by the way, the opioid overdose rate in France dropped by 80% in the first 5 years after buprenorphine's approval. So you'll see here, the blue line is overdose deaths and the red line is buprenorphine prescribing. Contrast this with the US, where opioid overdoses are now 5 times what they were when buprenorphine was approved in 2002. And based on my interviews with white and non-white people trying to access buprenorphine and stay on buprenorphine as a maintenance medication, I suggest that the public health potential of buprenorphine is limited by our race and class segregated market-driven healthcare system, in which patients that have patchy insurance coverage and tenuous access to prescribers have a difficult time not only getting on the medication, but staying on it. France has universal healthcare and also a robust social safety net. And these may be critical elements in their success with buprenorphine. So, for example, in my recent collaboration with sociologist Marie-Geoffrette Ristide of INSERM, which is the French equivalent to NIH, I've learned that there's much more to the story of buprenorphine in France. And one thing is that buprenorphine now and methadone is largely disseminated through a network of community-based sites that offer not only buprenorphine and methadone, but they also offer comprehensive medical care, mental health care, assistance with housing, assistance with employment, and also harm reduction services. So they also offer syringe exchange and in many sites, safe injection facilities. So contrast this with the US, where often buprenorphine is offered in sites that not only don't have social services or psychosocial supports, but are very segregated off from harm reduction services, many of which are actually still illegal in the US in most states and definitely do not get government support. They don't get government funding. So very different system. You have here in France a nationally coordinated network of integrated services located in the communities of the people that are needing the services. And then the other thing I want to highlight is, if we go back to this graph, you see in 1995, upper left-hand corner, 565 is the peak of overdose deaths in France. So that's 565 overdose deaths in a country of 60 million people, as opposed to 565,000 overdose deaths, which is closer to what it would be in the United States. So, you know, France never had an opioid crisis of the proportions that we have here. Why is that? Well, number one, France is a country where direct-to-consumer advertising is illegal, direct-to-prescriber advertising is illegal. I don't know how many of you know this, but the United States is one of only 2 countries in the globe where direct-to-consumer advertising is legalized. New Zealand is the other one. So we are the one that's out of the norm. France has a national review body for all newly proposed pharmaceuticals. So pharmaceutical manufacturers have to make a compelling argument and present data to this review body that a new medication is an improvement over an old one and that it's safe. All members of this review body have to pass muster as not having any links to pharmaceutical industries at all. So in contrast to the US, where, for example, the major FDA executive responsible for approving OxyContin went to work for Purdue Pharma 2 years later. So in France, they have a very rigorous review that's based on national interest rather than pharma interests. And in France, OxyContin was never approved, pure and simple. It was not seen as safe, and it was not seen as a significant improvement over other opioids. So this should make us skeptical about the power of the market to protect the public and rectify inequalities in health. In our for-profit healthcare system, buprenorphine maintenance has followed the pattern predicted by theorists of fundamental causes of disease, Bruce Link and Joe Phelan, that new biotechnologies in a setting of social inequalities such as we have here in the US, new biotechnologies will widen rather than narrow health inequalities if social drivers of health are not addressed. So contrary to the claims of pharmaceutical manufacturers and biotech manufacturers that this next new product will solve the problem of health inequalities, it's actually the opposite. That if social inequalities are not addressed first, new technologies widen the inequalities. And the problem of the opioid crisis and treatment highlights that. So the next point I want to make sure is make is that addiction is a biosocial problem. What do I mean by that? We should reconsider what it means that addiction is a quote unquote chronic brain disease. Basic neuroscientists are increasingly seeing the brain as a plastic, socially responsive organ that has evolved to adapt to complex social systems. Emerging life science models of neuroplasticity, epigenetics, and the microbiome have underscored that human biology is not a fixed entity, but it's dynamically shaped in interaction with the social environment. These more sophisticated biological models inherently call on us to invest in research on the impact of social systems and on interventions that create healthier social contexts, including robust social services and recovery support networks that give dignity, meaning, and structure to people's lives. So if we're to take seriously the comparison of drug dependence with diabetes, asthma, and hypertension, as my colleagues in addiction medicine keep repeating, we'd recognize that each of these conditions has strong social determinants and that success in their treatment and prevention requires, for example, social support, access to fresh food, safe, unpolluted, walkable neighborhoods, ... So any of you who've been involved with diabetes patients, asthma patients, hypertension patients know this, that it's not just the pill. And then lastly, deaths of despair call for racial and economic justice. Ann Case and Angus Deaton's 2015 report that came out just before the 2016 presidential election and fed kind of a discourse of the endangered white American, the report that pointed to the decline in US white life expectancy. This report was unusual in that its authors were not epidemiologists, they were economists. And their analysis of root causes of overdose, as well as suicides and cirrhosis, lay not in neuroreceptors and genetics, but in the deindustrialization of the American Rust Belt, where the departure of manufacturing and mining industries left behind high unemployment and social disintegration. A sociological study following their report showed overdose rates were linked to thin social networks. Accordingly, Ann Case and Angus Deaton have popularized the idea that overdoses are quote unquote deaths of despair. So I find their argument persuasive, and it calls for a social and economic revitalization through policies that promote social integration, stable employment with livable wages and benefits, and not just public-private partnerships to develop, quickly approve, and disseminate new medications for addiction, as are currently prioritized in the NIH HEAL initiative and the Cures Act, as well as President Trump's opioid commission. But Case and Deaton's focus on white people makes the analysis incomplete and makes Black and Latinx overdose deaths invisible. Case and Deaton do not have a clear explanation of why Black and Latinx life expectancy did not decline in the time period of their study. But I want to propose that Black and Latino people, Latinx people, saw an overdose crisis 30 to 40 years prior to this one, with the influx of heroin to inner city neighborhoods from the 1960s to 1980s. So at that time, blue collar workers in Black and Latinx neighborhoods were often barred from unions. They were the last hired, first fired. They saw massive unemployment much earlier than white workers who were initially protected by industrial discrimination. So this earlier Black and Latinx opioid crisis was not seen as a health crisis. Instead, it was reported in popular press as an epidemic of crime, leading to white flight from cities and further disinvestment from Black and Latinx city neighborhoods. So what we're left with is the survivors of this much earlier crisis, even as the CDC reports right now that Black men are the group with the fastest rising overdose death rate, due largely to lower tolerance after mass incarceration and exposure to fentanyl in street markets, ultra-potent synthetic opiates. While we work toward race and class justice and economic policy, we should use concern about the current opioid crisis to go beyond drug development and to invest in one, universal healthcare with psychosocial interventions, including trauma-informed therapy, attention to psychiatric comorbidity. This is very important for us as psychiatrists because that has not been emphasized in opioid policy and overdose policy at all. Peer navigation, recovery support, and assistance with housing and employment. And then second, we should divert people with opioid use disorder from the criminal legal system and promote treatment and harm reduction as a national response to opioids, not simply through local initiatives. So in New York City, for example, we have a program in Staten Island called Project Hope that has diverted over half of those arrested for low-level drug charges from sentencing to treatment, plus peer navigation. So that is assistance, peer support from someone with lived experience of substance use disorder. So the problem with Project Hope is it only operates in Staten Island, which is New York City's most affluent and whitest borough. Not, for instance, in the low-income Black and Latinx South Bronx, which now reports the largest number of overdose deaths. And where, by the way, sentencing continues, meaning in the South Bronx, sentencing on drug charges continues at high rates, and incarceration is itself now a risk factor for overdose post-release, when people have lowered tolerance to opioids after being in jail and prison for a time, and when they're under a lot of stress at high risk for relapse and exposed to a lot of brand new street markets, including with synthetic opioids, ultra-potent opioids such as fentanyl. So as long as it's up to empowered communities such as that in Staten Island who partnered with their district attorney to start Project Hope, decriminalization and treatment will focus on the white middle class. Lastly, public resources must be moved from drug development of magic bullets to research on and implementation of innovative biosocial community-based treatment approaches. So these approaches include peer-based recovery networks involving the arts, urban gardening, and community-based organizations, including spiritual or religious organizations. Let me see if I don't have a slide. I have colleagues that have done really creative work locating opioid use disorder treatment, substance use disorder treatment in, for example, Black and Latinx churches. Which are more trusted organizations, often with good reason, than clinics, where people have a history of a lot of experience with discrimination. And also, for example, offering buprenorphine in conjunction with spiritual healing at Native American centers, community centers. So a lot of creative work being done. These are approaches that necessarily integrate medications with recovery networks of support, harm reduction. As in France, they've done that. They've integrated treatment with harm reduction, as well as social services delivered by trusted community members and peers. And at this moment in the US, with 40 out of 50 states, actually more than 40 out of 50 states now reporting increases in overdose deaths since COVID, the toxic intersection of overdose use disorder with COVID is making this extremely urgent. Just look at the current COVID containment failures in the US based on profit motives, hoarding of tests and supplies, and the feeling among white people that it's possible to use technologies, including forthcoming vaccinations, to insulate themselves from Black and Latinx people who've suffered, and Native American people who suffered first in the COVID pandemic. So the proactive measures that I just outlined will help move us beyond incarceration and racialized for-profit biomedicine as these two polarized responses to drugs toward a public health approach that reduces the harm to both white people and people of color in our racialized drug industries. Thank you. And now I hope to have some time for conversation.
Thank you so much, Dr. Hansen. Please put your questions in the chat so we could judiciously get to each of your questions. Let's see. Here we go. So here's a question. I have read studies showing that patients of color are less likely to receive benzodiazepines for panic attacks. Also, children of color are less likely to receive stimulants for hyperactivity. Is this consistent with your research? And to what extent is this harmful to be deprived of these versus helpful to be protected from addiction risk?
Thank you. This is an excellent question, and it's in fact the question that prompted me to expand on the study of opioids that I just, race and opioids that I just outlined, to look at ethnic marketing of other psychotropic drugs, because we know that yes, it's true of benzodiazepines, actually all prescribed narcotics are going to be more freely prescribed to white people, in particular, more affluent white people. That's probably not a surprise. So it fits the pattern of the opioid crisis of marketing to a white middle class clientele. And then I'm very interested in this question of stimulants for example, ADHD, because that's another really well-established pattern that white, more affluent children are likely to get stimulant prescriptions for ADHD, whereas Black, brown, low-income children are much more likely to get second-generation antipsychotics with a sedating effect, and that's being used off-label in many cases. And the problem, so how do I interpret this? And what came out of my interviews around that inequality? White, affluent children, their parents are concerned about academic performance, correct? And stimulants have been shown, at least in a number of studies, to enhance academic performance, test scores, et cetera. So that's their primary concern. When it comes to Black and brown, low-income children, the concern is behavioral control in the classroom. And we also know that they tend to be diagnosed with oppositional defiant disorder, other kinds of disorders, as opposed to ADHD. But even among those diagnosed with ADHD, they're more likely to get a sedative than their white affluent counterparts. And that's because, quite literally, they're being prescribed these medications for different social purposes. On the one hand, enhancing academic performance for white, more affluent children. On the other hand, controlling children's behavior in the classroom, which is often overcrowded and understaffed. That's for low-income Black and brown children. So you asked, and so, you know, the next phase of this research for me is actually interviewing and observing pharmaceutical industry executives, and so developers and marketers, because I want to understand how this racial logic and coding actually takes place within the industry. I'm really fascinated by that. And what I'm discovering is that it's complex, that certainly for the vast majority of diagnoses, the initial market is a white, more affluent clientele that can pay high prices for newly patented drugs. And then as the lifespan of the drug progresses towards end of patent life, the company begins to scramble to open up new markets and new uses for their drug. And that's when they start to, for example, pay attention to ethnic marketing of the drug and perhaps research that would establish efficacy by race and ethnicity. And in a funny way, we're actually seeing that with opioids too. We're now seeing finally an opening of the public sector to buprenorphine. And there's a whole other logic evolving on the part of the pharmaceutical manufacturer around who's appropriate for buprenorphine. But you asked about the extent of its harmfulness versus its helpfulness to be or not to be a target for these kinds of medications. And of course, that's another complex story. I've tried to outline how in the case of opioids, the targeting of whites has hurt white people and people of color alike through different channels. And I think that's true also of benzodiazepines and stimulants, neither of which is without its risks, right? We know that each of those medications comes with risks. We know that if you've ever worked with college students, particularly at elite colleges, you know that stimulant, non-medical use of stimulants is pretty pervasive and that it can cause problems in many cases. We also know that benzodiazepines are often found alongside opioids in overdose death cases. So we know that benzodiazepines are quite widespread as contributing to a polydrug causation of overdose death. So these are definitely not without their harms. And so there's the problem of overprescribing for some targeted populations, and then there's the problem of underprescribing for non-targeted populations. And so just as with opioids, we're seeing now there's a big problem of underprescribing of opioids for Black and brown people that desperately need it. So when it comes to benzodiazepines, I haven't seen the primary research, but I'm gonna guess that that is also a pattern of benzodiazepine prescriptions. And then when it comes to stimulant prescriptions, you know, there are whole generations, cohorts of children of color who aren't getting appropriate support and treatment for symptoms that would meet criteria for ADHD. You know, another sub-theme of my talk has been the medicalization of social problems and how that plays out along racial lines. So when it comes to stimulant prescribing for ADHD, something I have personal experience with when it comes to my son and my daughter, I think that we can often, in the search for a magic bullet for ADHD as well, set aside really examining our educational systems and the things that we're asking otherwise healthy children to do during the day. Because there's definitely a strong relationship between behavioral, including ADHD issues in the classroom, and the crowding and understaffing of classrooms, and the reduction in budgets for physical education and activities. So, you know, to the degree that we are trying to solve social structural problems with medications, I think all children would benefit from more attention to the social structural root causes of, for example, skyrocketing rates of ADHD diagnoses along with behavioral diagnoses, like oppositional defiant behavior. So let's see, are there other questions? I know I'm running out of time.
Yes, there are. Can you speak about differences in pain treatment between white patients and patients of color?
Well, so there are a bunch of different studies documenting that patients of color are a lot less likely to be prescribed opioids under conditions where most clinicians would agree and their professional societies and their guidelines would agree it's appropriate. So for example, long bone fractures, you know, there's a classic study of children actually with long bone fractures, and they're much less likely if they're Black or Latinx to get opioids for those in the acute setting than white patients. So there have been studies in many different, so for trauma, you know, injury in the ER, lower rates of prescribing for Black and Latinx patients. There are lots and lots of different studies that replicate the same finding. And then I have a colleague who's an historian, Keith Whaley, who wrote a whole history of pain, if you really want to get into it. He wrote a whole history of pain that's a really subtle, detailed treatment of what we in the US see as a legitimate pain patient, who legitimately can get treated for pain. And there is certainly a long and deep racial history to that, a whole racial science around the fact that Black and brown people tolerated pain more, did not feel pain as acutely as white patients. Those are ideas that date back over a century, but actually more recent studies show that physicians still hold these beliefs, and certainly beliefs around propensity to abuse drugs. That's consistently shown when doctors are surveyed about it, that they are more likely to suspect Black and brown patients of risk of addiction or diversion. So I'm not sure if there was more to that question, but if you're interested in details, I'd recommend Keith Whaley's Pain. It's the history of pain in the US, and it's fascinating. It's also where he goes into how these debates around how different people experience pain and what makes legitimate pain has fed into national policies such as disability benefits, you know, SSI, like which diagnoses qualify you for disability and which don't, and which groups are disproportionately going to be affected by those rulings. That is also caught up with the long and fascinating history of legitimate versus illegitimate pain. So I highly recommend that book. Let's see, is there anything else?
We have hit the 1 o'clock mark.
Oh,
Unfortunately. I know I have to run, and many people do too. Thank you so much, Dr. Hansen. And
Thank you.
I'm sure you're going to get lots of emails with more questions.
Great questions. Yeah, I wish we had time to get into more depth. So next time I won't be as wordy.
And I'll shorten my introduction next time. How about that?
No, you're short.
All right. Take care, everyone, and be well. Bye-bye.
Thank you. Take care.